And welcome. I hope you had a good weekend since you probably came off wards, so hopefully you got a little time to recharge. What I wanted to talk to you guys about is mainly the main ACC AHA guidelines, the USPSTF guidelines. I know for some of you, you haven't had clinic in a while during med school, and then anything else you guys want to cover. So it's pretty straightforward. We are going to start in our morning clinic. So here's your morning clinic. Don't worry, your morning clinics will be lighter than this. You'll only have 3 people or 4 people. But so we're just going to go through each case, and then after that, we'll have cases where you can kind of pick and choose what you want. But I really want to go over, these are the basics in the first case. So case number 1 is a healthy 25-year-old patient who identifies as non-binary. They're coming in for an annual. So they've never had any blood tests at all. So other than HIV and now Hep C, I think you guys are aware of Hep C is now universal screening, possibly chlamydia testing, would you check a lipid panel? So who would check a lipid panel here? I see some faint head shaking. No one wants to check cholesterol. Andy's eating his oatmeal. No, just yeah, so we'll go over the guidelines for this. This is worthwhile doing. Okay, so let's talk about screening. So what age do you start then? If you guys don't want to start in this patient, when would you start? Let me know what you're thinking here.
I think 35 is what I remember.
35, okay. Any other votes? Guys, 40, 35 to 45, okay. Kim, are you saying a difference between male and female? Okay. Yeah, so you guys are thinking of some of the older guidelines. There was a difference in some of the older, like USPSTF guidelines, whether you're male or female. Yeah, good point. So this is good. We're going over this. So these are the guidelines. So the ACC-AHA says all adults over age 20, up to like age 80. If you made it to age 80 with never getting your cholesterol checked, that's impressive. But they basically say all adults. Now, the Preventive Services Task Force on the right, which is probably what some of you guys had remembered from before, their old guidelines, they now say age 40 and up. And then in the 20 to 40 age group, it's kind of shared decision-making, basically. It's if patient is interested, sure. If they're not, basically they don't say there's just not good enough evidence that we should screen all 25-year-olds. So the bottom line is it depends what guidelines you follow. So I would say at a minimum of age 40, they should get a cholesterol checked. And between age 20 and 40, if you follow the Heart Association guidelines, yeah, you should check it at least once just to make sure it's not sky high. And so this is something realistically you should talk to your patients in that 20 to 40 age group. So it's perfectly okay to check. You don't have to wait. There is no longer the age 35 and 45 male versus female gender. All that stuff's gone. All right. Okay. So again, at least by age 40, optional age 20 to 40. Any questions about that? It's actually pretty easy of all things. Okay.
What do you use?
What do I use? I do exactly what I said. At least by age 40, but between 20 and 40, I always offer it. If I'm doing lab work anyway, I say, hey, do you want your cholesterol checked? And if usually people say yes, right? They're not like, no, I definitely don't want it checked, right? But if somebody isn't getting lab drawn for any reason, they're super healthy, they've got no family history, I'm not like, you have to go get a blood draw. Like, yeah, you could skip it. Then I tell them, okay, at least by age 40, but if you want to get it sooner, just to screen, let me know. That's kind of my approach. If they have other risk factors, that's different, right? If they have early onset hypertension at age 30, yeah, I'm going to check it earlier. If they have diabetes earlier, then I'm going to check it earlier. But if they're otherwise completely healthy, then it's kind of optional. Yeah, good question.
Can I ask a question? Can you hear me?
Yeah, hey Kim, yeah.
Can you, is there a scenario where you'd actually run their risk and they'd actually be a candidate for a statin if they were in that young age group?
Yeah, we'll get into only the very, very, very high cholesterol folks would run into statins in the young age group. And then the risk calculator really starts at 40. You can use lifetime risk calculators under that, but honestly, I don't tend to do it. Yeah, good question. Because there's no guideline for if your lifetime risk is such and such, then check a lipid panel.
So is it just mostly for their knowledge and they can work on lifestyle stuff as a high?
Yes, and screening for very high cholesterols. You're screening for a familial syndrome under that age group. Yeah, good point, right? If you're 25 and it's a little high, yeah, it's lifestyle, right? And you're going to recommend lifestyle anyway to everybody, right? Exercise, eat healthy, etc. Yeah, good point. And that's why it's shared decision making. So you don't have to badger them into getting it between age 20 and 40 if they have no other risk factors, no family history. If they want to know, don't decline them. So yeah, sure. That's absolutely okay. And if you're getting blood for other reason, like HIV test or whatever, it's perfectly reasonable to check lipids. Okay. Repeat testing, we'll get into that. Okay. Okay, so this patient, so they said, yeah, why not? I actually have a positive family history of heart disease, so I might as well check it. And so they decide to check their cholesterol. So what are you going to order? So you've done your shared decision making, and they're like, yeah, let's do it. Are you going to get a fasting lipid panel, non-fasting, just the total and HDL? What do you guys like here? Yeah, we have a lot of fastings. Okay, so everyone likes fasting lipid panel? So a non-fasting. Okay, yeah. So you're both right. Okay, so I like that you all picked the lipid panel. There were some older guidelines of just getting a total in HDL. You don't need to do that anymore. Just order the lipid panel. You can get either fasting or non-fasting. It's really about patient convenience and what they're likely to do. Fasting's a little more accurate. So if you had your latte in the morning, your triglycerides might be high. But other than that, the non-fasting is pretty good. If the patient's willing to come back for a fasting, it's slightly more accurate, but that's another trip, it's another parking, et cetera. So I usually just work with my patient. For almost all of them, I just have them get it the same day, and so I don't really worry about it. But I do tell them, hey, if your triglycerides are really high, then you might have to recheck it. Okay, so yes, just order a lipid panel, and I would say fasting versus non-fasting really just depends on the patient, whether they want to come back or not. Okay, so here are the labs. So they were fortunately HIV and Hep C negative. Total cholesterol is 180, triglycerides 105, HDL is 45, and LDL is 120. So what do you think of this lipid panel? I know there's no like red or blue. You have to like actually know the numbers. So what do you think of it? Pretty good, says Camo. Anyone else? Yeah, this is pretty normal. Yeah, there's nothing. The total's under 200. HDL is fine. The LDL is not perfect, but it's not high either. So this is perfectly normal. So yes, so this is getting to the question what Andy was asking. When do you get repeat testing? So let's say they're normal. This patient's normal. You asked if they're increased. So when would you recheck it? So we've done their screening. They're age 25, and it's normal. So when would you guys recheck it? Or when would you recommend to the patient to recheck? So I see a 3 to 5 years, age 40, 5 years. Yeah, you guys are getting this. So for the Heart Association, they say every 4 to 6 years. For the USPSTF, they say every 5 years. Honestly, I don't know why you'd say every 4 to 6. I don't know, you just say every 5, right? It's basically the same thing. And they said, of course you can check it sooner than that, but no one really knows how often you should check these things. So if you're normal, every 5 years is fine. But for Lauren, who said age 40, yes, in this case, I gave you a patient who's very young. If they're very young, it's normal and nothing else changes clinically, yeah, you could wait till 40 and then do it every 5 years. That would be like a USPSTF guideline. That would be perfectly fine. If it's abnormal, which is I think what Andy was asking, yeah, I think it depends if they do anything. So if it's a little high and they really work on diet and exercise and they want to check it again, perfectly okay to check it again. Then it's a matter of when they want that feedback. If they want that feedback in a few months to see if it changed, yeah, you could do it as soon as a few months. If they just want to check it in a year, work on it for a year, if they're young and low risk, that's okay too. If you put them on meds, it's a different story. Does that answer your question, Andy? Okay, so when to recheck? Yeah, so if they're totally normal, generally every 5 years. If it's before age 40, you could wait till age 40, absolutely. Okay, any questions about that? Screening when to start. Okay, it's pretty straightforward. This is not the hard part. Yeah, that's true. Case number 2, 50-year-old woman. She has no medical conditions. Her pronouns are she and her. She is a non-smoker. Her blood pressure is 130/70, and she had a screening lipid panel drawn, which I'm showing you on the right. Her total cholesterol is 190, triglycerides 160, LDL is 135, and her HDL is 45. So, first question, is this primary or secondary prevention? Primary, right? Yeah, it's not a trick question. Yeah, primary prevention. She hasn't had a stroke. She hasn't had a heart attack, etc. Exactly. What do you think her risk is? Low, moderate, high? Any thoughts on this? And again, I know a lot of you guys haven't done a ton of outpatient. Lowish, lowish. Yeah, exactly, right? She's 50. Numbers don't look too bad, right? Your gut feeling is low. You are absolutely correct. So if you plug in her numbers, so for those of you who are fast on your apps at home or on the computer, you should be getting about 1.5% 10-year risk. At least at Roosevelt, all our computers, you can pull this up just on the internet in the room with your patient, or you can use an app, whatever your preference is. Yeah, so her risk comes out low. And what's the recommendation here in terms of, do we start drugs on her or not? Yeah, no. Yes, right. I hope all of you said no. The Heart Association guidelines, under 5% 10-year risk, no drug therapy recommended. So absolutely. So low 10-year risk, continue lifestyle measures, whatever she's doing already, and no statin drug. Any questions about that? Yeah, this one's fairly easy. Okay, let's go to the next case. We have now, she is 68, has basically the same lipid panel, but is older than before. And her 10-year risk is now 8%. So now what do you think the recommendation is? Give you a sec to think about that. So you think she's now medium risk? Okay, that's fair. And what about her, Jordan says threshold of 7.5%. Okay, and so what would be recommended at these thresholds? Start a statin, and what kind of statin? How much, how little, moderate, okay. And low to medium, low to moderate. Okay, let's look at this. So right now I'm going over the Heart Association guidelines. So less than 5%, we said nothing. They give this small kind of small window, 5 to 7.5, where they say, well, you can kind of go either way. At 7.5 to 20%, they say moderate dose. Okay, so they don't say low to moderate dose in these guidelines. They say go right to moderate dose. And again, it's the Heart Association guidelines. And then over 20%, they say high intensity. This might be a little different than you recall because these updates were from 2018. So again, depending when you last did primary care, you might have been operating under the 2013 guidelines. Slight changes, very slight. Okay, so she's at 8%, so moderate intensity statin therapy could be offered based on the Heart Association guidelines. And then the nice thing with the new set of guidelines, if you ever read them, is they really talk a lot more about shared decision making. So it's not like just 8%, go give them a drug. You really should talk about it with the patient. So at 8%, according to the Heart Association, she's got 8% risk. Those of you who remember that 7.5 threshold, you're right. And so you could offer moderate intensity statin therapy, and then of course, definitely shared decision making. Do you know what else you take into account in this shared decision making conversation, at least according to the Heart Association? What do you guys think? Age? Not really. Well, okay. These guidelines are for age, for starting will be age 40 to 75. So that's incorporated within the guidelines. Yeah, family history. Do they have other conditions? Yeah, could they change could they make lifestyle changes? Exactly. Yeah, so you guys are right about all those things. If you actually look at the guidelines, what they recommend, part of what you take into account is this. You definitely don't have to memorize this. But these are all things actually that if you have them, it would more tilt you toward treatment, right? These are basically other risk factors. And so there's a little bit of a bias toward treatment in these guidelines, but all the other things you guys mentioned, absolutely. So you could think about other things that might tip the scale. And again, you can look these up, but they're pretty obvious. Okay, so again, for general primary prevention, according to the ACCHA guidelines, less than 5%, no statin, 5 to 7.5, maybe moderate dose, 7.5 to 20 moderate dose, over 20% is considered high risk, and high dose statin therapy is recommended. Any questions about that? Okay, and again, once you do this for a while, you kind of memorize it. I don't know that you have to memorize it. I think if you can get to the point of checking a lipid panel and then, calculating the risk and then looking at the guidelines, you're probably okay. But I think this is easy enough to memorize. Plus, when you rotate through cardiology, they're going to expect you to know this. So I would probably just commit this to memory personally. Okay, next case here. Okay, this time it's this same age, 68. This patient identifies as male and is a non-smoker, has normal blood pressure. That's the cholesterol panel that you see on the right. Total 180, LDL 120, HDL 45. And of course, if you're on your app, you can probably calculate it faster than I can read this off. But what do you think his 10-year risk is? Do you think it's higher or lower than the last case, I guess? Oh, I've lost Erica. That's a bad sign. Oh, there we go. Sorry. If I see someone walking away from their Zoom screen, it's a bad sign, right? No, I'm just. So what do you think? Is this patient? Do you think this patient's risk is higher than the last case or lower? Any ideas? Maybe lower. Yeah, maybe the cholesterol panel is not too bad. Yeah, so the key difference is this patient is male. So so if you play with the 10-year risk scale, yeah, again, you don't have a calculator in your head. I realize that. So the men tend to have higher risk than women. For women it lags. So if you calculate this risk, hold on a sec. There we go. It's about 12%. And again, if you can play along at home. So what do you think the recommendation is at 12? Do you remember? We just went over this, of course. Moderate. Yes, thank you. So, but then so absolutely, right? Heart association, 12% risk, moderate dose statin. You're done, right? No, of course you do shared decision making. But then he says to you, hey, my blood pressure is pretty good, and my cholesterol, it's normal. Nothing looks red on the printout, right? So he says, why should I take a statin, right? And so if you look, just say I put a theoretical patient, they have a normal blood pressure of 110/70. They have average lipids. It's not like the most perfect, but it's pretty good. No other risk factors. What age do you think you have to be to make that heart association 7.5% threshold? Yeah, like Kim's saying. So pretty much every man over a certain age should consider statin. Yeah, so if I give you these numbers, what age do you have to be to make that 7.5? So Lauren's saying 63. Anything else? Their ideas? Yeah. Yeah, so you guys are absolutely right. It depends how perfect you make the blood pressure and how perfect you make the cholesterol. But in general, for men, to get to the 7.5%, the threshold's age 62. About 63 if you make them have even better lipids. And for women, it's about 71. So yes, just by age and gender alone, you can meet these thresholds. All right. And then I put other thresholds there as well. And again, you can easily do this on your own just by punching in the numbers and changing the parameters. So yes, you could say yes, because you're alive, you met criteria for statin therapy. Good job. So it's kind of tricky, right? And so this patient asks you, aren't there other guidelines? So who among you have read the USPS TF guidelines? Any show of hands at all? Yeah, I know you've been slogging through the wards. Okay, so some of you have. Yeah, I know your last year of med school is like a lot of electives and inpatient stuff. So yeah, so let's go over these guidelines. These are pretty important. So the Heart Association I'm putting up there, hopefully you know this by now. According to the USPSTF, they have slightly different thresholds. So their don't start a drug threshold is 7.5 instead of 5. So a little higher, right? And their maybe start a drug is 7.5 to 10. All right, so everything is inched up a little bit. And then they don't really have this kind of moderate to high, separation. It's just everything over 10%, consider a statin. And if you look at the dosing, it's different too. It's low to moderate. And the reason they're saying low to moderate is most of the primary prevention studies, most of them, not all, used low to moderate doses. And there's another thing you need. Do you guys remember or know what else for the USPSTF? You need something, it can't just be a percent threshold. Are you guys familiar with this at all? Not really. Okay. So you also need a risk factor. Okay. So you can't just be alive, right? You have to have something else that tips you toward therapy. So what they say is you need to also have a risk factor such as diabetes, hypertension, smoking, or what they call dyslipidemia, which is an LDL over 130 or a low HDL. It's a pretty low bar to make this threshold, right? Because a lot of people in this country will make that threshold. But it is different. It doesn't mean that, like, if you're totally healthy and your numbers are perfect, and you're, 70-year-old person, you don't have to, you wouldn't be recommended based on this particular guideline. So that's one of the key differences, and that's what I wanted to make you aware of. So to put them side by side, right, this is kind of what it looks like. So it's different. And so what I think it's easiest to remember is Heart Association threshold is about 7.5%, moderate to high dose. USPSTF is 10%, low to moderate, and a risk factor. So any questions about that? Kim's asking, do I use one guideline or another? But I'll get to that in a sec. Any questions about these two guidelines and the similarities and differences? Pause you there first. Let you guys ponder that for a sec. You like one over the other? Just curious. Do you prefer to use one guideline over the other? USPSTF does not recommend high intensity for primary prevention. That is correct. Almost every primary prevention study, not all of them, almost everyone used low to moderate doses, and that's why they did not recommend high intensity. Yeah, so Kim's asking, do I use one guideline over another? Honestly, I tell patients both. You know what? When there's two major societies, even if there's someone in conflict, I think it makes sense to make patients be aware that there are different guidelines. If you really like one over the other, I mean, you're doctors, you can decide to promote one over the other. That is totally your call. If you're more of a USPSTF person, yeah, you can do that. But it's very possible the patient may then look up and find the Heart Association guidelines and be like, hey, why didn't you, offer me this? And then you'd have to explain, well, I use these other guidelines. These are both such big guidelines that I think it's very fair to show differences. So I will have some patients where I'd say, you know what? Heart Association would say you meet criteria for statin drug, but this other group says you probably could wait. And so I have those conversations all the time. And then you're really talking about shared decision making and values. But I think it's perfectly legit to tell patients when there are two guidelines that are not exactly the same. The differences are subtle, right? It took me several cases to even tell highly trained medical residents the difference. So it's hard to explain to patients. So which recommendation group got more money from statin companies? Yeah, good question. I have another talk on guidelines and how you should look up who you have to go deep to find their financial disclosures. USPSTF is very good. The United Kingdom guidelines are very good. They have full disclosures, good processes. Specialty guidelines in the US typically stink. The Heart Association's gotten a lot better though. A lot, like they're much more transparent and they have much fewer people with conflicts than they used to. So they're a million times better than they used to be. But yes, they do have people with pharma ties, absolutely. Yep, good question. But again, I have a whole other talk on how to look at these guidelines critically. Other questions or comments? Oh, sorry, Kim was asking, the evidence for ACC Rex, the evidence is exactly the same, right? So, and these are not dumb people, right? Smart people from the Heart Association, smart people from the USPSTF, they looked at the exact same set of evidence and they came up with a different guideline. All right, so the evidence is completely the same. And so, yeah, when you make a guideline, you're talking about values, judgment, interpretation, right? Same evidence. So anyway, it's quite interesting, but I think it's worthwhile knowing both, making patients aware of both. If they're really low risk and the guidelines agree, great, you don't have to worry about it. But there will be quite a few intermediate scenarios. So question for you, how many people do you think in the US meet these criteria? You guys have any idea? Throw out a number. Lots, thank you. It's not a number, but that's okay. 60%, okay, not quite that much. For the Heart Association, it's about 40 million, and for the USPSTF, it's about 27 million. It's still a lot of people, but the point is, if you did follow the USPSTF guidelines, 13 million fewer people would be treated. So there is a difference, on a population scale. Obviously, in an individual patient, you're going to do some shared decision making. Okay, so to summarize this case, yes, he meets one set of criteria, but he doesn't meet the other set of criteria because he does not have an additional risk factor. So this is definitely shared decision-making time. So no knee-jerk statins, and definitely not on the water supply, thank you. All right, any other questions about that one? Okay. All right, next case, let me just see how I'm doing on time, good. 60-year-old woman, her pronouns are she and her and hers, and she has type 2 diabetes for 5 years, does not smoke. She does have hypertension, but you treated it well. The blood pressure of 110/70. She has no known microvascular disease. Her 10-year risk is about 10%, and her numbers I'm giving you there. Total of 150, triglycerides 230, LDL 95, and HDL 40. So do you guys know what the Heart Association recommendation is here for statin drugs? And then we'll do the USPSTF also. So what do you guys think? So diabetes, statin, high dose statin maybe, okay. So you're all saying statin, at least. Yeah, so that's correct, right? This is for the heart association, this is a different category. It is still primary prevention, but for diabetes. So, it's the same age group because there are a lot of cautions for people older than that in terms of the studies. But for age 40 to 75, the recommendation is moderate intensity statin. Now, you notice I gave you a 10-year risk, but they don't actually use that for people with diabetes. They're just like, diabetes, moderate intensity statin. And so you don't need to use the 10-year risk if you follow the Heart Association guidelines. And then you can consider high intensity, and this is a little more vague. You can calculate the risk if you want, and you can consider what's called risk enhancers, which are here. I'll summarize it a little bit, but basically it's, you've had diabetes a long time, right? They call that over 10 years of type 2. And then microvascular disease and PAD, basically. So that's if the patient has higher risk, maybe they have chronic kidney disease already, or they have neuropathy, then you can talk with the patient. Hey, do you want to do a high intensity statin instead of moderate? That's kind of the Heart Association guideline. So moderate for everybody, maybe go to high intensity, and you can look up those risk enhancers. I would not memorize them. Okay. And they're not actually using the 10-year risk estimate. Any questions about that? It's actually a lot simpler guideline. Okay. And then what about the USPSTF, right? We just went over this. So what would the USPSTF say for this patient? So remember, they're a 10% risk threshold and a risk factor. And diabetes is a risk factor. So it's already incorporated in their guidelines. So they would say low to moderate. Yes, you guys are all saying moderate. Technically, they say low to moderate. So remember, USP, I'll put this up one more time. So they have a risk, diabetes is the risk factor. It's over 10%. I gave you the 10-year risk, and so they would say low to moderate dose. All of you said moderate. I'm with you, actually. I think there's good evidence that moderate doses and people with diabetes is evidence-based, because that many studies use moderate dose statin therapy in people with diabetes. So I would use a moderate dose personally in this particular case. And again, you'd be agreeing with all the guidelines. So yes, so the Heart Association says moderate intensity. This patient does not have risk enhancers or additional risk factors. And the USPSTF would say low to moderate. If you want to split the difference, since we're general internists, right? We compromise, right? Moderate for everybody. So I think that's the easiest way to remember it. Any questions on this? You guys are good with that? Okay, so patients with diabetes, moderate, generally moderate, maybe consider high. And then last case for this particular section, this is a 32-year-old woman. Her pronouns are she and hers, and she presents with insurance physical labs. Has anyone gotten life insurance? You guys are too young, right? Yeah. So they actually will measure your cholesterol and check HIV, check if you smoke, and all that kind of stuff, because they're pretty smart about this. So this person got labs under 8, but it could have been any. You could have drawn them too under age 40 just for screening, and her total is 290. Triglycerides 140, HDL is 40, and the LDL is 220. So what do you guys think about this? So statin, huh? Yeah, so this was getting at to what you guys were asking earlier. So what if you are in the younger group? When would you start a statin? And see, Jordan's writing LDL over 190. Saying surprising. Yes, it is surprising. This is the whole point of screening younger people, is sometimes you get folks like this, or their total's like 350. I always say anytime your LDL looks like a total, that's bad, right? So for the Heart Association, if your LDL is over 190, this is considered high risk. And you should really kind of start asking them a little bit more. Say, tell me your family history again. The recommendation is maximally tolerated statin therapy, which is basically high intensity statin therapy if they can tolerate it. There's a lot more in the guidelines in this particular category. Like if you don't get to under 50%, start reducing by 50% to add this, then add that, et cetera. I wouldn't bother memorizing it. I would just try to remember, okay, if I've got my screening and my LDL is sky high over 190, I should think about familial syndromes, think about treating earlier, and then you can look up the rest for that one. So this is a separate category in the Heart Association. The USPSTF does not address familial syndromes. They address general primary prevention. Okay. Questions about that? Okay, and so yes, this one you pretty much would only use the Heart Association guidelines. So maximally tolerate statin, just really check their family history a little bit more. If you're having trouble getting their cholesterol down, you know, it's a reasonable referral to the lipid clinic if you have such a specialty. Okay, so let's go back. So to summarize here, so again, for these morning cases, screening age 40, between age 20 and 40, you can go either way. You can do a fasting or a non-fasting lipid panel. For general primary prevention, for these next set of cases, those are the thresholds and the differences between the Heart Association and the USPSTF. For diabetes, the Heart Association says moderate statin, maybe high dose if they have risk factors. For the USPSTF, it's incorporated in their whole recommendation anyway. And for the super high LDL group, the recommendation is high dose statin and think about family history. Any questions on those set of cases? You guys good with that? Okay, all right. Okay, we're gonna go to the afternoon. So this one, I'm gonna let you guys pick. So I'm gonna let you look at this for a sec because I kind of want this to be learner driven. And I have way more cases than I can do in an hour. So first case is hospital follow-up for someone with heart disease. Second one is you starting statins. Now what do you do? Third one is side effects. Fourth is coronary scores. The fifth is more about shared decision making. The next one is about risk calculators. And the last one is somebody who is over 75. What would you guys like to cover next? Let you look at it for just a second or two. Okay, a lot of votes here. Definitely you guys want CAC and then starting and okay, got it. So let's actually do, there are the most votes for coronary artery calcium score. I just have a little bit on this. So who's ever ordered a coronary artery calcium score before? Okay, I mean, even as a student, I realize you probably could, unless you ordered it the last 2 days, you probably never ordered one. You probably did not order it inpatient. Okay, so the coronary artery calcium score. So first of all, I've been talking a lot about the so-called ASCVD 10-year risk, but what does it actually mean? So in other words, what does it mean when you have a 10-year risk? So whose risk is it? Is it the risk of your patient? Like, what do you tell patients it actually means? Do you say like, yes, you have a 15% risk or you have a 5% risk? You guys are probably like, I haven't had this conversation because I've been in clinic for 2 days. Yeah, because it's not really the risk of the patient, right? It's the risk of people with that profile, right? So 50-year-old, whatever, male with this cholesterol and this blood pressure. Yeah, exactly what comes right. It's the approximate risk. So of people like you or with your profile, they expect 100 of them will have this number of heart attack or strokes in the next 10 years. It's not your actual risk, right? Nobody knows what a patient's actual future holds, right? So it's predicted events in people with a similar profile. And so that's important language in terms of shared decision making and patient education. So the coronary artery calcium score, it's actually really old. It's been around for a long time. And they look at the amount of calcium in the coronaries, and it's done with a modified CT scan. And calcium roughly correlates with plaque, which roughly correlates with disease. It doesn't tell you about plaque stability and all that stuff, right? It's a picture, it's an image. But it is quite predictive of ensuing cardiovascular events. And it spits out a number, basically from 0 to numbers in the hundreds or even low thousands. And so if you look at the Heart Association guidelines on when they say you could consider using one of these, this is for someone in a moderate risk category, like maybe 7.5 to 20%. And they just kind of can't decide about statins, right? They kind of meet criteria, but they're kind of on the fence. So they say, well, you could get one of these coronary artery calcium scores. Because if it's 0, right, even though their profile shows high risk, the likelihood of them having a heart attack with a 0 score is extremely low. It's so low that taking a statin probably doesn't make sense to prevent heart attack. It doesn't tell you about their carotids, but at least It's a proxy. So they're saying, well, gosh, what if your risk is 12% or 15%, but you have a 0 calcium score? Then not taking a statin is quite reasonable. And then if you're intermediate, like 1 to 99, they say, well, you're kind of stuck again right where you were. They say, well, if you're intermediate and you're over age 55, maybe take the statin anyway. And if you're over 100, they say, well, you should take a statin. And of course, this is the Heart Association guidelines, so their biases are more toward preventing heart disease, right? Which may or may not be right. But anyway, so that's kind of what they're saying about this. In terms of costs, it's actually not that bad. It's not like ordering a brain MRI. This is more in the hundreds. Insurance may or may not cover. So at least at Roosevelt, I tell them, well, I'm going to order it. Before you get it done with radiology, have them make sure they check your insurance, see what damage you're in for. And then VA coverage, I'm not quite certain on. And then there's radiation, and then could be incidental findings. The incidental findings are much fewer because they really try to only look at this area. They're not looking at your lungs unless they caught a tiny bit of it. So you're much less likely to find, lung nodules, et cetera, than before. So, but there are risks, right? It seems silly to, irradiate someone just so that they don't have to take a statin, right? That seems kind of silly, right? But for some people where they really can't decide and you're really struggling with it, it's actually not a bad thing to do. So I order maybe like 1 or 2 of these a year, just to give you some example. So not very frequently. Usually based on their risk factors and values and preferences, you can kind of make a decision about statin therapy. But again, the value of this is the patient's own coronary plaque, right? It's not their, profile based on 100 people like them based on some. Although again, you have to irradiate them and spend some money to get this data. So I'm not, and when this first came out, I was kind of like, hell no, I'll never order that. But now I can kind of see it. There's a niche role to it. Okay. Any questions about coronary artery calcium scores that get to what you guys were asking? Yeah, it's not a bad test actually, but again, the question is, what does it add to what you already know? And it usually doesn't add a ton, but sometimes it does. I do have one patient who, her numbers, would say she's higher, at least moderate risk, but she's got a score of 0. So I'm like, I'm not putting you on statin drugs. It works out fine. But so I think there's a niche role for this. So yes, you should consider it. The other ones were started statin. Now what? Okay, so let's talk about monitoring, because this is probably pretty common what you're going to run into. You've got a 65-year-old patient, and you decide to start a statin for primary prevention. You went through their risk score, you went through shared decision-making, all that good stuff. And make sure you got observed too. So anyway, what labs do you need at baseline? What do you need to check before you start the drug? You already checked their cholesterol, we know that. So liver enzymes, okay. Okay, yep. Excellent. Anyone? It's CK. Oh, okay, we'll talk about that. So now you only need baseline liver enzymes. There used to be guidelines where you check more, like CK and things like that. That's changed in the recent guidelines. So just baseline liver enzymes. You're basically looking for pre-existing liver disease that you should know that you weren't aware of before. Okay, so you check their baseline liver enzymes. They're fine. You put them on the statin, and a few weeks later, your patient sends you a message. Of course, if you're in my clinic, your attendings are going to be checking your messages at that point. But and they say, "Oh, what about rechecking stuff?" So, what do you need to recheck after starting statin drugs? So nothing or symptoms. So you guys don't want to check liver enzymes again. Very nice. Thank you very much. So, and then what about the lipid panel itself? They're like, I'm taking the drug. When should I recheck to see if it did anything? Three to 6 months. Okay. 3 months. Got some different ideas. Yeah. Okay, so for lipid panels, official guidelines, if you put them on treatment 4 to 12 weeks, and there's some expected reductions, whether you target that or not is controversial. They say it's to assess adherence and response. I think that's kind of bogus. I think for adherence, I just talk to my patient, but and then every 3 to 12 months. So realistically, if the patient wants to see if it did something, and if you're going to actually titrate, then 3 months is quite reasonable. if it's primary prevention, you're just going to put them on it and see what happens, then 1 year would be fine for rechecking the lipid panel. So it depends how actively you want to monitor and titrate. And then I'm going to skip that since we're not talking about secondary prevention. And then other labs, you guys are absolutely right. You don't need to recheck anything else. So old guidelines were to follow the liver enzymes. Now you don't have to unless there's some sign of problem. So again, baseline liver enzymes only. And then for rechecking the cholesterol panel, yeah, 4 to 12 weeks if you're titrating, looking for that feedback. Once a year if it's primary prevention is quite reasonable. Any questions on that? Is good with that? Okay, all right. That's straightforward. Okay, side effects. Let's talk about this. So this is probably the single biggest question you're going to get probably in primary care about statin drugs is about all the side effects because patients are often super worried about this. So let's start with the first one. So my patient has, sorry, 1 second here, muscle aches on statin. What do you do next? You say, my muscles hurt. I think it's from my statin drug. So Alex says lower the dose. Jordan says stop the statin, check a CK level. Kim says do a different statin. Get more history, right? Maybe they just, maybe they were rowing, right? So characterize the muscle aches better. Yeah, is this like really myopathy? And then change statin. Yep, you guys are all correct. So, okay, so this is straightforward. You guys know this pretty well. Yeah, so the first one is believe your patient. At least acknowledge that it could be the statin, right? I've actually seen some physicians and some cardiologists just kind of blow it off completely. They're like, nah, it's definitely not your statin. And then you can see the patient kind of shrink back because they're like, I think it's my statin. And so it's just something where, you know, maybe you're right, maybe it's not their statin, but I think you got to run with it a little bit and work with it. So absolutely believe them, say, huh, okay, let's think about it. Maybe it is from your statin. And you're right, you are going to get more history. I won't get into all that. If you really think they have myopathy, like their pain is horrible, they're getting weakness, yes, then definitely check a CK level. If they're just kind of achy and they have a normal exam, it still could be their statin, and that would be more myalgias instead of myopathy. And you guys are absolutely right. You got all these. You could stop it and restart it at the same one at a lower dose because some of the myalgias are dose dependent and myopathy is dose dependent. You could try a different statin. So those of you said pravastatin, you're absolutely right. That tends to have fewer myalgias. And then there's even some guidelines for doing 2 to 3 times a week because some of them are longer acting. So like atorvastatin, you can do 3 times a week. Sounds kind of nuts, but you can do it. Since you're in Seattle, those of you not from Seattle, people like supplements here. So red yeast rice, sometimes people use. I don't necessarily recommend that. It's basically just a tiny dose of a natural statin. CoQ10 is super popular. If patients want to take it, and that'll keep them taking their statin, I'm fine with it, but there's not good data. There were some initial data that looked promising, but not anymore. CoQ10 is totally safe, so if they want to take it, it's fine with me. And then anytime that a patient's having trouble with a drug I'm giving them, I have to think, okay, why am I giving them this drug again? How badly do they need it? If they had 2 MIs, I'm going to try to gut them through it without any gaps in treatment, right? If it's totally just primary prevention, maybe they're at 8% risk, I feel pretty good stopping it for a while and then starting again at something else or starting lower. So anytime there's a problem with the drug, yeah, I go back and think, okay, what was the indication for the statin? How high risk are they? What was that shared decision-making conversation? And does this tip the balance now that they might be having actual side effects, right? And then Kim's asking if they should be on moderate and you restart it low. Yeah, absolutely. Yep. Again, if for somebody who's primary prevention and I want to get them to moderate, yeah, I don't need to get them there tomorrow. You know, I need to get them there eventually. So yeah, starting low, working your way up, especially if you have a patient who doesn't tolerate meds well in general, perfectly okay. If it's secondary prevention, they're really high risk, I'm going to get them going a little faster, or I might switch them, you know, right, just say they're on simvastatin, which is kind of old school. I might switch them right to atorvastatin or rosuvastatin or some other statin at a reasonably high dose if they need to be on it. So again, it depends what their risk level is. Does that make sense? Yeah, it's a good question. Yeah, so some people I'll go slow, some people I'm not. I'm going to try to keep them very high. Like they just had a stroke, they don't like this statin. I'm keeping them on a different, but a different statin. Absolutely. So you're going to run into this a lot. Any other questions about statin and muscle issues? I'm just looking at the chat here. Okay. Okay, next question. Have you guys heard this before? Do statins cause diabetes? Is that I've never heard of it, or they don't cause diabetes? I didn't ask a very good question there. Never heard of it. Okay, sorry, there was another question about muscle aches. Let me go back to that real quick here. For the statin-use myalgias, yeah, so pravastatin and rosuvastatin tend to cause fewer muscle, but idiosyncratic. Some patients, you can't always tell. Yeah, that's a good question. Okay, back to the statin is causing diabetes. The answer is actually probably. I hate to say it. So it first started in the Jupiter trial, which was this primary prevention high-dose Crestor or rosuvastatin trial. It's one of the few primary prevention trials where they used high doses. And then in this paper, they said, oh, actually, more people in the statin group had new onset diabetes. And so then they went back and looked at all the other statin trials, and they said, oh, okay, this seems like a real thing, actually, because wherever they look, they seem to find it. It seems to be a pretty low incidence. It's more like the numbers vary between 1 in 300 and 1 in 500, something like that. And it seems to be that your blood sugars just go up a little bit. So if your blood sugar was 120, taking a statin might push you over that 126 threshold, and then you're now diagnosed with diabetes. So it doesn't seem to take a totally normal person and give them like hyperosmolar state. But there is some evidence that it does raise blood sugars. There's even some evidence that it might up the A1C in some people who have diabetes. So this is probably real. Okay, it's not 100%, but there's enough. There's like multiple studies finding this, that it's probably real, but it's probably a small effect. Despite that, there's not a recommendation to screen more, frequently in people who are on statin drugs. Okay. How about this one? Do statins cause memory problems? Have you heard this one before? There's a lot of people are super worried about that. Yeah. So the answer is maybe. There's just this isn't like the same data as with the myalgias and the same data as with the blood sugars. These are just case reports. Usually elderly patients, they get a statin, they get confused. You take them off the statin, they get better. So I would kind of put this more in the drug-induced delirium category personally. There's no evidence that it causes dementia, but that's definitely been a thing. I've heard that many times. I don't want to take a statin because it causes dementia. I'm like, it doesn't cause dementia. At least we have no evidence of that. Of course, to really prove causing dementia, you'd have to study them for like 20 years. So there's always some unknowns with that. Okay, my statin, I don't want to take a statin because it's going to hurt my kidneys. What do you guys think about this one? See puzzled looks. So yes, don't think it has any kidney problems. All right. So this is kind of unclear. There are some reports of statins causing proteinuria, but it doesn't seem like it actually does anything in terms of kidney function. This is kind of like when statins raise your liver enzymes a little bit, and we just kind of say, okay, sure. So it's not really clear if this is significant. And then there was one study, just like a database study, not a randomized trial, saying maybe there was some more acute kidney injury, but that's far from clear. So I would say this is kind of unknown. I'm not generally too worried about it, although I know some people are. So I put this in so if my patient asks me about it, I tell them, yeah, there's some reports about protein, but I don't think I haven't seen it that significant yet. Okay, those are the main side effects I wanted to get to. It is 8:50. I'm keeping an eye on time because I want to make sure you guys have a break before your next one. And then the other question I saw, PCSK9, that's a whole other topic. PCSK9 should be used for the highest risk patients. So familial syndromes or people coming back in with their MI over and over and they don't tolerate statins or you can't get them low enough. If it's a normal primary prevention patient having myalgias and they can't take statins, I don't put them on PCSK9s. Full disclosure, I've never actually prescribed one because it's a huge pain to prescribe it. So usually by the time they have that many secondary events, they have a cardiologist and they're usually prescribing that. Okay, I'm gonna stop there. Anyone who wants to go break for 10 minutes before the 9 o'clock lecture, but any other questions on anything? Fibrates, fish oil, etc. Okay, I can do that one if you want. Do you guys, and anything else? Okay, again, it's 8:50. Those of you who want to take a 10-minute break, totally cool. I'm gonna do the fish oil thing real quick here. But like I said, totally fine if you want to take off. So non-statins. I focused on statins because almost all the evidence is on statins. I'm not going to do the case just to save time. But basically, For triglycerides, if they're very high, you usually treat that to avoid pancreatitis, although the evidence is not that great. And then niacin, nobody uses niacin anymore, unless you're in the lipid clinic, because all the data is terrible for niacin. It causes more harm, doesn't seem to prevent any actual events. So you can just completely cross niacin off. I'm going to skip bile acid resins. Again, nobody uses that at all. So fenofibrate gemfibrozil, mainly to lower triglycerides if they're sky high or if you need it in addition. So I'm going to skip that too. Niacin, like I said, just don't use it. Nobody uses those anymore. Fish oil, I should mention just briefly. Have you heard of Vascepa or Vasc EPA? Yeah, some of you are nodding. Cardiologists love this now. So there's different kinds of fish oil. I'm just going to, in general, it was never clear if it did anything. Most of the data that fish oil is good is in people who eat more fish, like real food, as opposed to supplements. But there was a trial called Reduce It that came out recently, and it randomized people to this particular form of fish oil. And basically what they found was that there were fewer events. So this is actually kind of exciting. So a lot of the cardiologists are now putting people on this. And my only caution for that for you guys is, yeah, you have to know the inclusion criteria, which you don't have to remember, which is here. But also, this is just one trial. Previously for fish oil, they had a trial that it reduced sudden cardiac death, and then when they tried to repeat it, it didn't work. So I would love to see another trial to really show that this is real, that it doesn't get turned over later. That being said, it seems reasonably safe. So in appropriate patients, so this is more secondary prevention, they have cardiovascular disease and another risk factor like diabetes, there is some evidence for this it's called VIS-CEPA. And so you'll see the cardiologists prescribing this a lot now. So there's some emerging new data on the fish oil. But for all the rest of the non-statins, other than fibrates for lowering triglycerides, pretty much don't use it. HDL raising drugs, those came out for a while. They raised HDL sky high, but it killed people, so we don't use those. Ezetimibe, secondary prevention. There is some weak data for that, so you can definitely think about adding that on. All the slides are available. You can look at that later. And then the PCSK9, there's really good evidence they really lower cholesterol a ton, and the recommendations are mainly for really bad secondary prevention or familial syndromes. So that's kind of like the whirlwind kind of non-statins. So there's a lot on this. These slides are online. I think they are. Anyway, so they should be. I've sent them to Whitney, so they should be online. You can always look these up later. All right. Let me go back here. Give me one sec. Okay. I'm going to let you guys go. If you have any other questions, you can always email me. Those of you in Roosevelt, you can just come by and ask. You'll see some differences in practice style with statin therapy between cardiology, primary care, et cetera. And that's totally fine. You'll develop your own styles for this. And otherwise, enjoy immersion. I hope you guys get some good weather and can recharge before your next inpatient month. And I'll see you guys later. Okay, thanks.